welcome. We may have a small group, but I was telling Dr. Riley that we tape everything, so anybody who misses things, we have a lot of people who go into the Interfaith Library to get copies of the presentations. So they usually get posted a few weeks after each presentation. So the presentations so far this year were taken in today because I have to take them in on Sunday morning, and depends on when I'm over here. So as usual, we're going to start with a prayer. And based on our own personal experience this year and the topic of this conversation, this is an alternative serenity prayer that Bert and I found very helpful this year. So, God, grant me the serenity to stop beating myself for not doing things perfectly, the courage to forgive myself because I'm working on doing better, and the wisdom to know that you already love me just the way I am. Amen. So our speaker today is Dr. Riley, and he sent me a lovely introduction. Most of our speakers don't give me something that is really usable. It's normally full of acronyms, and it's like yay long, and so. Dr. Anthony Riley is the Chief Medical Officer of Gilchrist. Gilchrist was founded in 1944 as a hospice organization and has now extended its services to any individual with a chronic or serious illness needing a coordinated approach to care. He oversees a medical practice of nearly 50 physicians and nurse practitioners, one of which my husband saw at Encore. And she's the daughter of parishioners who regularly attend these events. So they provide geriatric, palliative medicine, hospice, and medical director services across the Baltimore region. Dr. Riley is an expert and frequent lecturer on doctor-patient communication and medical decision-making in serious illness. So I want to welcome Dr. Riley. He came highly recommended from St. John the Baptist congregation and Sandra Pico, and they raved. They just said it was one of the most phenomenal presentations they've ever had, and no pressure. So, okay. And here we go.
It was up here, and there it is. So, in my role as the medical director for Gilchrist, I've spent a lot of time talking with professionals, families, and patients who have dealt with serious illness and progressive illnesses. Give me a sense of who's in the audience. Have you prepared your own advanced care planning documents already? Because I know this is the third year, most of you have done that already. And are you caregivers of others who are in your family? Yes. And anyone else that I should know about in the audience? My comments, I'll try to stay focused on caring for patients who've had diseases of the brain and nervous system. And I would like to use the analogy, and forgive me if this seems trite, but a medical illness isn't a single event. It's really a journey. And it's a skill to navigate that journey. And as you probably have learned, there's lots and lots of decisions that need to be made, and your decision making gets better with time and experience. So part of today will be sharing with you excuse me, some approaches on that journey. And I'm going to focus on the decision-making rather than the forms, because I think, as you've indicated, many of you have already done the forms. Let's see. Oh, down. Thank you. So, as asked by Audrey, I'm going to focus on diseases of the nervous system and the brain. And the first category is the acute catastrophic condition. It's the traumatic injury and the stroke. The second is the very long progressive illnesses such as Alzheimer's disease. And then the chronic progressive disease that is defined by physical impairment like amyotrophic lateral sclerosis, or ALS. Each has a slightly different perspective. You all have already done, I'm sorry, I'm going the wrong. You all have already done your advanced directive, so you probably know the answer to the question as to why to do this. I'll review some of the reasons why it's such an important thing to do, and to do it well. It will have a significant impact on your life and, more importantly, I think, your family legacy. Many times that aspect isn't talked about, but I think it does. Any serious illness is a family illness. It affects all members of the family. So just as a will is essential for the stewardship of financial assets, an advanced care plan is essential for the stewardship of your values, your family relationships, and your life story. So that's the reason to do this, and I hope to convince you of that, although I suspect you've already done this, so it may not take so much convincing. We all realize that significant medical decisions can impact the rest of our lives. And for patients with serious or progressive illnesses, the consequences of decisions can be great, and the decision-making itself is pretty tricky. As this chart illustrates, the underlying health condition impacts the likelihood of recovery after an event, even with treatment. This is a fundamental concept in our medical decision-making. For example, if you're a healthy individual, many of these decisions are pretty simple and straightforward because the benefits of the treatments typically outweigh the burdens of those treatments. For example, if I this evening were to suffer an acute stroke, my wife and I are very clear that I would want to have every opportunity for treatments. I'm basically a healthy individual, and the treatments that are available to try to mitigate and to reduce the risks and the injuries from that stroke can be very, very helpful. And as we'll learn later in the talk, not every treatment has 100% benefit, and many of our medical treatments have burdens. So there's going to be a weighing of the benefits and the burdens. But typically, for the healthy individual, the decisions are simple because the benefits almost always outweigh the burdens that might, and the risks that might come with that treatment. For patients with serious or progressive illness, many interventions can cause more harm than good. That may come as a surprise to non-medical audiences, that treatments they have benefits and burdens, and the likelihood of benefiting from treatments becomes less as you have progressive or serious illnesses. I'll explain why as we go through. But the basic reason for that is that patients who've had progressive or serious illness, there's been a loss of the basic ability to recover. All of us have a certain amount of physiologic reserves for recovery, that after an injury or an illness, we draw upon those reserves to help us come back, help us bounce back. And for individuals with serious or life-limiting illness, that ability to recover, those reserves, have been depleted by the preceding illnesses. And so the ability to recover diminishes as the illness progresses. That means the benefits of the interventions are diminished, and then the burdens and the side effects are there. So when you weigh the benefits and the burdens, it may be that the burdens and side effects of potential interventions outweigh any benefits. So this is why I'm very glad that you're here, because this is what I have to do and talk to when families and patients are in the midst of medical events. We're having to talk through, what are we going to do? So you will have a framework for making those difficult and tricky decisions for you. And that's also why advanced care planning is so important, because this happens pretty fast in the medical situation, and to have an idea in advance of what you want to do is helpful. As I just explained, this is mostly about benefits and burdens, and to individualize and tailor your decision-making is an important part of making sure that it's the right thing for you. There's no one-size-fits-all in these decision-makings, particularly if your loved one or you have a progressive illness. So advanced care planning allows you to do this kind of individualization. It needs to be deliberate. There needs to be this risk-benefit assessments and treatment decisions. And particularly remembering that those patients, those family members that have progressive or serious life-limiting illnesses, those physical and mental reserves for recovery are quite limited, and more harm may come from aggressive treatments. Medical events and decisions also can complicate the family realm as well. Aubrey and I were talking earlier. These medical events can cause fractures in families. There can be conflicts, and these conflicts can threaten the family legacy that you're hoping to leave behind. And family members who are not prepared, who do not know your wishes, they tend to get into arguments among themselves during times of crisis. And this can result in permanent, sometimes permanent family relationships and family fractures. Conflicts occur from out-of-town relatives, such as angry cousin Lester here. I've had a finger shaken at me many times by the out-of-towners who feel like they know the person, they're there with good intentions, but they haven't seen that person perhaps in 5 years, and yet feel confident that they know what the person might have wanted and know their wishes. Family members also get into conflict over the legal and medical and financial and other professionals that you haven't shared your wishes with. So, as we were talking earlier, it's very important to involve the family in these kind of care planning sessions. The thoughtful planning helps avoid some of those unnecessary disagreements and helps preserve the family legacy and harmony that you're working so hard for. And those who have done advanced care planning often say that this is one of the gifts that they're giving to their family. I don't know if you've already experienced that when you've talked about it with your family. So I hope that briefly reviews why it's important to do advanced care planning. And so I'd like to spend the rest of the time talking about navigation. How do you make this journey? And what are some of the twists and the turns that I'll help you to anticipate? And so the whole idea of this advanced care planning is to put you in the driver's seat and to be successful in your choice of where you're headed. That's really the whole idea, is so that you're in the driver's seat. So the first step is enlist a driving companion. You all have done your advanced directives already, it sounds like most of you have, so that you've already chosen a healthcare agent. How many have you all have agents? Yes. That's a critical first step, because the agent in the state of Maryland has the power to make decisions on your behalf when you're unable to. And for some of us, I've designated my wife to make my decisions for me, even if I'm able to. There is that option. I don't have to be incapable to have my agent make my decisions. I have many couples that have done that. That's because if you're in the midst of a medical emergency or catastrophic injury of some sort, even though you may have capacity and may have the ability to make the decisions, how good are they going to be? I've talked that over with my wife, and she and I have said that these healthcare agent appointments go into effect upon signing, not upon my incapacity or my wife's incapacity. That's a nuance. Many people don't want to give that amount of control to their wife or spouse. But that's a kind of question to consider as you're talking to and preparing your agent. How are they going to decide? Designating an agent applies to anyone of any age. In fact, much of the law and many of the many cases that we know about were the result of injuries to healthy young people. Karen Ann Quinlan, Terry Schiavo are examples of young people that were involved in these controversial decision-making. And so appointing an agent is something every person should do regardless of their age. It's probably one of the easier steps to take when you're doing your advanced care planning. So continuing with the road trip analogy, you want to understand where you've been. What's the road that you've just traveled? And that means, do you understand the condition that you have and what happened? I find that in talking to many patients and families, the technical term is the medical debrief. When I'm first meeting a family and patient, I ask, what's your understanding of what happened? And it's remarkable that many patients and families aren't really clear about what happened. So these are some questions to ask yourself so that you get a very good idea, or if you don't know the answer to these questions, get them. You can talk to your physician, your nurse practitioner, so that you really understand the road that you just traveled. How did you end up this way? What was the underlying condition? And then these other questions help give you a sense of the changes over time. It's pretty difficult to do this sometimes. One is the medical team may feel like, oh, that's past. But as I hinted, knowing what your condition is really important because it helps you assess am I able to recover the next time? Do I have the reserves to bounce back if something should happen again? So it's part of preparing to make some pretty challenging decisions. So this is where are you right now? And as I said, you talk to your physician about this or the nurse practitioner so that you understand where you are in this continuum of health. Forgive me if I say this, but many times when I talk to patients who are over on the right-hand side there, they have very serious illnesses. When I talk to them and ask them how they think they're doing, many times the physical reality that I understand as a physician doesn't match with their understanding of their condition. They don't realize how sick and how seriously ill they are. I view that as pretty normal and natural. All of us want to feel better we just want to feel better about ourselves. And so it's a natural thing for us to underestimate the conditions that we have. So it takes a fair amount of discussion and a critical look at what you have and discussions with your medical team. How serious is this condition? This is hard to do, but as I indicated in the beginning, it's important to know where you are on this sort of health continuum, because your decision-making changes as that condition changes and as the seriousness of it changes. An important factor to consider as well as we get ready to make decisions is, what's the quality of life? What is my current quality of life? I've had many discussions with patients and families about quality of life, and everyone focuses on things a little bit differently. So quality of life means one thing for you, and quality of life means another thing for another individual. Yes. 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 So the question was, will I give some examples of quality of life discussions and what some people think about? So I'm a geriatrician, so I see many patients who are older. And for me, 85 is about the right time to start seeing a geriatrician. If you're younger than 85, you're way too young for me. So many of my patients are in their 90s, and I have a whole handful of patients who are over 100 years old. And for them, quality of life means different things. I had one lady who said to me, you know, it's really, really important to me to be able to play bridge. And then she says, competitively. She set a pretty high threshold for what a cognitive quality of life meant for her in terms of her ability and competitive ability to play bridge. I have had others say to me, what's really important to me that I recognize and am able to communicate with my family. And so we work very hard to do those things. There wasn't much I could do for the lady who wanted to play competitive bridge. But it does help you know kind of what is the goal that you wish to attain when you have to weigh treatments. Are these treatments going to help improve your quality of life? And so you need to have an idea, well, what is the quality of life? What is important to me? For many men, mobility and the ability to get around, driving, they would say, my quality of life is greatly diminished because of my loss of mobility and ability to drive. you'd think, well, how do you make medical decisions on that basis? Wouldn't most people want medical treatments if it accomplished other things, other quality of life things? But for some people, certain things are way more important than others. That's the whole idea behind quality of life factors in your decision making. That's how we make it very individual. And we should not, I as the doctor, shouldn't assume what some of these quality of life factors are for individuals. I only know if I can, if I ask them and talk about it. I have some of my patients, this is the last example and then I'll move on, where their physical comfort is very, very important. This is particularly true in the hospice work that I do. They'll say to me, "Doc, it's very, very important that I be physically comfortable." And they say, "Give me as much medication as it takes for me to be physically comfortable." They don't want me to hold back. And I say, "Well, how about if you have side effects?" Sometimes those pain medicines cause sedation. And the person that says that my physical comfort is the most important thing to me, they'll say, "If I have a hint of pain," literally a person said this to me, "if I have the hint of pain, give me more pain medicines, even though it makes me sedated." That's not a decision that I would have made for that patient. That's not a decision I would want the family to make for that patient. But that's an example of how that individual was using a quality of life factor in making treatment decisions. Does that answer your question about how that might be useful in making decisions? On the other hand, I've also had patients who say, "I'm willing to endure great physical discomfort in order to stay mentally clear." So you see the other side of it too, that their quality of life wasn't so much about their physical comfort, but it was about their ability to communicate. And so sedation from pain medicines would be unacceptable to them. So to help patients and families consider what their decision-making style is, I ask them to consider, what's your decision-making style? And I have 3 categories for patients, just to be simple. There's the warrior patient, there's the diplomat patient, and then there's the pacifist. I'll describe all 3 and then ask for your show of hands, if you will, are willing, sort of what kind of decision-maker are you? So the warrior patient is willing to endure significant side effects and suffering, and suffer against all odds and at all cost for any hope of beating the disease. This is the patient you see that's featured in the Baltimore Sun as a heroic patient, fighting for her life, fighting cancer, fighting Alzheimer's disease. They're lauded for their courage and willingness to fight their disease. They may be a believer in the promise of technology and new drug development to produce the medical miracle down the road. And the warrior patient also sees that the many resources devoted to his or her care reflects their value to themselves, their family, and to society at large. And for this patient, obtaining medical care is the top priority in their life. I have patients that I care for in hospice who are warrior patients. They want everything, even though the benefit might be tiny, even though the burdens might be great. This is them. That's their personality. That's their decision-making. A warrior patient's medical story becomes the key part of their life story. The diplomat is a little bit different. In contrast, they like to consider a range of factors in deciding whether to pursue treatment, particularly if the likelihood of benefit is low. This is the kind of patient that isn't likely to volunteer for Alzheimer's therapeutic trials, for example. The warrior patient is first up for those medical research studies. This patient may favor time with family over time spent seeking medical care. This patient typically pursues treatments that offer reasonable likelihood of success, but reject those long-shot treatments. And this patient, the diplomat patient, typically derives a sense of importance from engagement with the family during the illness. This is the kind of patient that is not like the warrior that's going to travel to New York City to live there for weeks to get an experimental type of treatment. That would be too hard on the family. The pacifist patient is the peacemaker type patient. This patient rejects most, if not all, medical interventions should they become seriously ill. They see this most often, or I see this most often in my elderly patients who feel they lived a full life and they're seeking a peaceful decline and passage. I have a patient that I care for who's 108 years old, and she is at peace with her life. She's reconciled all this, and in her mind, she's looking for a peaceful, quiet passage. She's not looking for the medical heroics that would be found in a warrior patient. And she may even be trading off some treatments that I would offer her that she would reject. I would think they would be beneficial for her, but she is looking for a peaceful passage, not necessarily prolonging her passage. The pacifist doesn't wish to risk worsening an already frail or fragile state of health to live just a little bit longer. And the pacifist accepts that the next illness may cause death. So patients typically fall into the first two categories, warriors and diplomats, until the later stages of their disease and illness. It's rare that I have a patient that says they're a pacifist when they're healthy. There are a few of them, though. So articulating which philosophy, which style best describes your decision-making will enable you to, I think, be prepared to confront new situations more confidently. You say, this is the way I am. This is my style. Does this categorization of patient styles resonate with you? So how many are warriors? Yeah, I generally find a few. It's not the majority, though. How many are diplomats? Yeah. Yes, the comment in the audience is it depends on your condition and how old you are. Exactly. So it's very common for younger audiences to be in one or the first two categories and not be in the pacifist category. So as you choose your style, you'll see clear differences in the level of risk that patients are willing to take and the burdens they're willing to take to tolerate when they are accepting treatments. And so it's important to remember that in current medical decision-making, the patient and the family have the right to accept or reject treatment based on how you all, the patient, perceive the burdens and the risks versus the benefits of their own situation. I say that because as the doctor, I often have a perspective. And I feel like my job is to share my perspective as to what I think should be done. That's guidance. But ultimately, you have the right to accept or reject those. And I think understanding what your style is helps you know and to be more confident that you might be able to resist the recommendation from the physician. Docs don't know. We know technically what to do. We know how to treat pneumonia. We know how to do things. But we don't know, when you weigh all the factors that are being considered, what is the best decision for you. That's what truly, when we talk about patient-centered medical decision-making, that's what that means, is that you all get to make those decisions. I have the obligation of sharing with you what the options are and of making a recommendation, but you all have the right to make your own decisions. So let me keep moving on. Is this okay? Are we going in the right direction in this journey? Are you still on the bus with me? So the next step is to anticipate the road ahead. So you begin to apply what you know of your history, what your condition is, what your decision-making style is, and now you'll be ready to make some decisions. Let me give you another insight. One technique that we use to help patients anticipate what's ahead is to describe the disease path. This is the part that I call the anticipatory guidance. Our pediatricians do that very well. Our other physicians caring for adults are very reluctant to talk about what's ahead. But that's really what you need to know, because you know what's already happened, you know what your condition is, but you want to know what's the path ahead. What's the road going to be like ahead? In this graphic, a middle-aged patient experiences an acute stroke, which leads to a rapid decline. The patient receives treatment, that's where the red X is, and recovers almost to where he or she started. In some patients, this recovery may take a long time. In others, it may be relatively rapid. So in the moment, it's very hard to know what that path is going to be like, but that's a question to ask of your doctors to help you anticipate the path that you're going to face. In the case of this situation, it was a middle-aged patient who had strong physical and mental reserves, and she was able to recover almost fully, to get back to baseline. So if you're in this situation in which you have an underlying and your health is good, you would favor more aggressive intervention because you're likely to get the benefits from them. And on balance, the benefits of the treatments, the benefits is always going to be in this hand. The benefits of the treatments outweigh the burdens of the treatment. In this situation, if I have symptoms of a stroke, I would like to go to the hospital. I'd like to get the clot-dissolving treatments. I'd like to get vigorous monitoring of my condition in a neuro-intensive care unit. I'd like to get physical therapy, occupational therapy. I want to see, because I started out healthy. I have hope that I'm going to climb back rapidly back to baseline. So at the moment, I think the benefits of the treatment outweigh the burdens and the hassles of, 6 hours of therapy every day, or the risk of that clot buster causing things to be worse through bleeding. So that's one type of path. So as you consider the illness that you have and talk with your physician, know what's ahead. Ask about what's down the road. In stroke, there are studies that can give you that information, and the doctors should be able to tell you what are the success rates of recovery. In Alzheimer's disease, the doctor can tell you what that looks like over time. It's often difficult to hear because sometimes it's not optimistic. This is a different type of disease path. Here's an older patient with early dementia who has some heart or lung disease, who has a pneumonia after being stable for a period of even years. That's the acute event. They develop a pneumonia and get very, very sick. Treatment is initiated with antibiotics, but you know what? They're not bouncing back as quickly. I think there's a pointer here. They're not bouncing back as quickly. And they may never get back to baseline condition. And then they have another event, and they don't recover to even the reduced baseline. And so you have that stepwise decline. And if the patient at this stage, this was the pneumonia, this is a minor stroke, for example, they may recover some, but again, not back to baseline. The patient's condition deteriorates. They receive treatment. The condition improves, but not back to baseline. And partly that's because if they've had a stroke at this point, because of their underlying condition, their heart and lungs, they may not be able to tolerate physical therapy. They get too tired, too short of breath. And because of the baseline cognitive, the dementia, they can't follow the physical therapist instructions well. So the benefits of the treatment, the physical therapies, diminishes, while the burdens of them, the loss of energy, the shortness of breath, and the fatigue associated with the therapy may outweigh. So your decisions may be different, even for something as seemingly innocuous as physical therapy. So knowing this, in the later stages of this patient that has the little bit of heart and lung and cognitive decline, they may choose to decline and reject certain aggressive treatments because the potential for benefit decreases as their decline in health decreases. And the potential for having only burdens and side effects increases. We see this in patients who go back and forth to the hospital. I'll talk specifically about hospitalizations as a specific decision. But the benefits of hospitalization for patients that have serious or end-stage disease diminish over time. They don't really get better because the hospital isn't really fixing the underlying organ failure, the heart failure or the lung failure. So knowing your history and the extent to which you've bounced back from prior illnesses is an important piece of knowledge to help understand where you're headed and what kinds of treatments might be useful for you. And this will help your physician as well if they don't know you very well. Unfortunately, many of these decisions get made by physicians in the emergency department or in the hospital, and they don't know you like your family physician does. So you're going to have to help them and tell them. Going to shift gears a little bit and get more specific with the cognitive. These are the individuals that have cognitive or mental deficits and aren't thinking as sharply as they were before. And there are a number of things that can happen. These deficits impact the ability of the patient to report his or her medical history and current state of health. It affects their ability to give consent and to comply with treatment. And they may have personal awareness defects, situational awareness defects, memory deficits, and impairments in their judgment. So what does it mean if you don't have the cognitive awareness and personal awareness? Your ability to recognize symptoms is impaired. One of the things that we do every day as healthy, cognitively intact individuals is that we do a mental scan of our body. How am I feeling today? How many of you do that? I'll bet we all do that. And if we have a cognitive deficit, say from Alzheimer's, even mild or moderate Alzheimer's, that cognitive function diminishes and we're not scanning how we feel that day. And unless we have a caregiver that recognizes that we're off a little bit today, that illness that's brewing may get to a pretty extreme condition before it's recognized. That's why an illness such as a urinary tract infection in patients suffering with dementia can be so catastrophic, because it doesn't get recognized early, because the patient fails to recognize and has a loss of personal awareness. They may also have situational awareness deficits. They may not understand why they've been taken to the emergency department. And in their lack of understanding why they're there, they may resist or reject treatment. It makes it very hard when the patient doesn't understand why someone is coming at them with a needle. The memory deficit is pretty obvious. They may not remember what their medical history is. And it's not unusual for physicians and nurses who have known this patient over years, for that patient who now has memory deficits to reject that provider because I don't know this doctor, I want my other doctor. They don't recognize that I've been caring for them for years. And as I hinted with the physical therapy, part of therapy is to remember the exercises. And when patients suffer with dementia, they may not be able to comply and remember how to do their physical therapy exercises. And they may not be able to comply with any treatment regimen. So they need a lot of assistance to get medications, for example. And then there's obviously the errors in judgment. This is especially important in early dementia, to help and to recognize that their judgment might be off. For me, as a physician assessing my older patients, when they reject a treatment, for example, I have to be careful and ask, is this patient capable of making this decision? Or do I need to turn to their healthcare agent to help make these decisions? Because it may be an error in judgment. They may not be able to process the risks and the benefits of the treatments that I'm proposing. Speech deficits are significant in that medical history may be difficult to report on. Again, communication about symptoms and questions is impaired. And the ability to convey consent may also be impaired. And then the comprehension deficits, I alluded to that already in terms of the judgment. If people don't understand because they've had the cognitive impairments or injuries, it limits their ability to give consent. And I want to know as the physician that this is something my patient agrees with. It's not me that should be deciding these things. Any questions on how these cognitive deficits impact the care and decision making?
I just wondered what you do with people if they don't understand what you're doing or they're doing.
Yes. So the question is, what do you do to help people who don't understand what you're attempting to do? So for patients with mild or early dementia, you have to make it simple, right? You break the tasks down. From a medical perspective, one of the best things that I can do for patients is to make their medication regimen as simple as possible. That means once a day. As soon as I ask a family member or a patient to have medicines given more than once a day, the likelihood that they're going to be able to comply with that drops significantly. So I try to keep it simple. Keep the word simple that you use to explain what you're doing. And I have a 2-year-old grandson. And part of it is, and I don't mean any disrespect to my elders, it has to be really simple so that a child could understand what you're doing. That means telling them what you're going to do, telling them that you're going to do it now, telling them all the steps as you go, so that they have a chance to process, albeit slowly, what's happening to them. Because none of us likes to be caught up in a situation where things just happen to us, right? Where we've lost control. I don't know what happened to the screen, and I've lost control of the screen. Question?
Earlier, you outlined clearly about the risks versus the benefits of one pain medication.
Yes.
Well, if you're at an advanced stage and you need more medication than once a day because you don't want pain at all,
Yes.
then I want that wish honored, not the once a day.
Yeah, so the question is, for medicines that have to be given more than once a day, we then have to look for other ways of getting that medication into the individual. Often it means enlisting others, or I have a patient who has a device at home that the daughter fills the device with the medicines, and twice a day it will set off an alarm for her father to go to this machine. Out comes the drug, and it's a simplified robotic medication dispenser. You can spend thousands on these machines that can be controlled remotely by family or by a schedule, and with all kinds of bells and whistles. So there are some technological solutions to those problems, but in general, keeping it simple is the best rule.
Okay, so what happens when you have an elderly patient who has already been determined incapable of
Yes.
making their decisions, and you're trying to follow the wishes that were written down for that person agreed to years ago, and now they're belligerent about doing what they had originally decided on when they were lucid, but that's opposite or different than what they're saying now, and they're mentally incapacitated to make good decisions.
Yes. So one of the things about advanced directives is that they are like a financial will in that they're durable, meaning they continue to be in effect beyond the time of their incapacity. So that if they were capable at the time they wrote their directives, these directives then are considered, you should follow them even in the event of the patient's rejection of whatever the wish was. Now, that may put the family in a very difficult situation, as you're alluding to probably. And setting aside those directives should not be done lightly. And most institutions, hospitals, nursing facilities, have ethics committees that will help resolve that conflict if the family is unable to make that decision or feels like the directives should or should not be followed in light of the patient's objections. So there are a number of avenues that you can choose to do. It depends on the decision, and it depends on this is where understanding the patient's style. If this patient was a warrior all of their lives and actively sought out every treatment and indicated in their directive that even after I've become incapable, I want things done, then it would be respectful of that person's medical story, life story, to carry on even though you might disagree as a family member right at this time. I don't know the situation that you're alluding to and to which of the issues it is, but again, this is how you would go about analyzing whether that advanced directive is still valid. An ethics committee can help sort that out. Understanding that past of how they sought medical care and how they valued medical care is also helpful. I have used that myself in helping to judge whether the patient's intentions were, whatever it was that they wanted or didn't want are still in place. Does that answer the question enough to be helpful?
A little bit. What we're dealing with is a person who, according to their advanced directives, wants to be intubated,
Yes.
go through the whole process.
Yes.
But yet the facility is saying to me, the advanced directives are supposed to be evaluated every year, but yet she's really not capable of
Yes.
doing that. And so my family is, how do we go about this?
Yes.
How do we evaluate without her input and also being respectful of her wishes?
Yes.
When clearly the medical system doesn't really want to intubate her. So that's the dilemma.
Yes, and I suspect that it was. And a close read of the directive, what were the exact words might be helpful, because sometimes those directives are written in a way that gives discretion to the healthcare agent. This is a MOLST form. I'm going to get to the difference between a directive and a MOLST. Yes. Yes. I think I've lost the slide again. Oh, it's over there. Sorry. So one of the things that I do recommend for families and patients in the midst of medical decision-making is to plan for periodic rest stops. This is the review of the directives. This gives you the time and the space to reconsider. It also gives you the time and the space to reinforce. If your loved one with that advance directive had reviewed it every year religiously and said, even though now I'm 10 years older, I still want to be intubated and to have CPR, you're getting a better sense that this is a durable wish, not one done 10 years ago without any further consideration. So the periodic review of these things helps reinforce the durability of those wishes. And so making these periodic rest stops is what I call it, using the journey analogy, is an important part of helping really to understand, have my thoughts changed about this? Have my values changed about medical care? And that's because things do change over time. And you now have the advantage of insights that you gain from living with your disease. Do people know Stephen Hawking? He's the astrophysicist. Many people who get ALS, the amyotrophic lateral sclerosis, Lou Gehrig's disease, make declarations at the beginning of the disease about what they do or don't want. Oh, I never want to be on a ventilator, or I would never want tube feedings. But as the disease unfolds, they may change their mind as they experience it. Stephen Hawking was a successful, productive astrophysicist on a ventilator, receiving tube feeding. So the quality of life for him was his mental capabilities and his ability to do his life's work as an astrophysicist. That's why the quality of life is so important for individuals to decide what's important to them. Because Stephen Hawking obviously tolerated the burdens of the tube feedings and the ventilator in exchange for the quality of life that he thought was the most important. It's not unusual for individuals over time as they gain experience with their illness. ALS is one of those illnesses that can be years long with retention of complete cognition so that they have a chance to thoughtfully consider their situation, and they may change their thoughts over time. Patients with new diagnosis of Alzheimer's may make certain statements, but after an experience into moderate dementia, they may change their minds too, and they may be capable of making those decision changes as well. So that's why the periodic review is so important, so that you're using the insights that you have from living with the disease to inform your decision making at this time. The other reason to periodically assess where you are in your route is that treatments change and improve over time. You may receive new information about existing treatments or learn about new ones that would change the course, change that disease path. And sometimes the doctor may not talk about that as much, about what's new, because we all get into a routine. And the visits may go in a rather routine way. So having these checkpoints where you periodically assess where you're headed is an important way to use that to ask the question, what's new on the research front? Ask that of your physician so that you know what's coming. I have some patients who are suffering from Alzheimer's, and they ask me that question every visit. You can understand why. They don't want to be inadvertently not able to access that treatment at a time that might be beneficial to them. And over time, your decisions hopefully get better as you learn how to do this better and live with your illness. So the periodic reappraisal helps make you a better decision maker and to individualize your treatment decisions. This is another piece of advice that often I give, and it's irritating to the medical team sometimes, but unless there's a really, really good reason that there's a true emergency that requires very prompt intervention, take your time in making decisions. Slow that decision-making process down. The urgency that you feel in the emergency room often isn't a medical urgency. And don't be pushed into making decisions on the spur of the moment. So slow it down, take the rest stop when necessary, particularly if you feel overwhelmed, because it'll help make better decisions. Hospitals are not the best place to make medical decisions. If you all have been in hospitals, you know it's chaotic. There's lots of activities that are going on. There's an emphasis on speed and urgency and moving you through the system. And they operate according to protocols that sometimes are opaque, and they haven't certainly shared with you what those protocols are. But those protocols are telling them to do X, Y, and Z. There's nothing wrong with the protocol because it reminds clinicians that they should consider doing these things. It doesn't tell them to do them. And you, as the decision makers, should be in the driver's seat and driving that bus. And if it's moving too fast, ask the question, when do I need to make this decision? And if they say it's life and death today, or life and death at this moment, well, then maybe you have to make a quick decision. But if you really don't have to make that decision right at this moment, take the time to step back and to apply your decision-making skills that you're learning. How do we think about these decisions? In those highly pressurized situations, even an hour or two will help you feel more confident about making decisions. It always feels like that in a hospital. You've got to make the decision right now. And the doc is right in front of you, and they're pushing for things to be done. It doesn't have to be that way many, many times. So take the breath when you're feeling overwhelmed, and to take that rest stop. This is now a discussion of documents. If you've done this work, now you have to put it into writings, and you've already done advanced directives, so this part will be easy for you. And you already know about, I think if you've been part of the work that's being done here at St. John's already, Horizons Foundation has done a fair amount of work in how to store these advanced directives so that they can be readily accessible. So you need to make sure everyone has copies of your advanced directives so that everyone gets them for easy retrieval and understanding. And then these documents, as I have alluded, update them, because they're easy to update. You don't need an attorney to really update them again. Now this goes to the question someone had about the MOLST versus the advanced directive. Have people seen this before in their work when completing these documents? The advanced directive is a legal document that's authored by the patient. The MOLST is authored by the physician, and it's an order. The advance directive typically goes into effect upon incapacity, but can go into effect upon signing, whereas the MOLST goes into effect immediately upon completion. These are some of the differences between these documents. And advance directive focuses on conditions such as a persistent vegetative state, a chronic degenerative state, or an end-stage terminal condition. And advance directives typically only apply if one of those conditions is present. If those conditions are not present, those advance directives don't apply. I'll bet you didn't know that in the language. The MOLST order, on the other hand, applies to specific interventions like CPR, like ventilators, like dialysis, regardless of the condition. There's a big difference there. And the advance directive, no matter how legally notarized it is not recognized by the EMS personnel. I think most of you probably know that because you've been through some of these before. Whereas the MOLST order is the only order in the home that the EMS team, the emergency medical staff team, responds to. Any questions about this slide? Yes.
What is the difference between a MOLST and a DNR? Is the MOLST just broader?
Okay. So a MOLST is the Maryland Order for Life-Sustaining Therapies. So the MOLST contains these kind of orders. The biggest one, and on the first page one, is the CPR decision. The others that are listed there under the MOLST order are on page 2 and refer to common types of decisions. Transfer to the hospital, fluids and nutrition, artificial ventilation, blood transfusions, antibiotics, dialysis. So these are the treatment decisions that are addressed with the MOLST order. The ones I've highlighted in red are the ones I'm going to talk about. If you want me to talk about some other ones, let me know, and I can certainly modify as I go.
I have a little word of warning. So our experience, won't name facilities. I was asked, do you have an advance directive? Do you have a MOLST? And I said, yes, we had an advance directive. No, we hadn't done the MOLST yet. And yes, I was the health agent. And when we got to the third facility, we found out that someone had filled out the MOLST without my knowledge at all. And it was completely opposite
Yes.
what our wishes were. Is it legal for a hospital to fill out one of those documents without talking to the person or their health agent?
No, it is not compliant with the law that says in the very front page of the MOLST order is who is making this decision, and it can be the patient, it can be the healthcare agent, it can be a surrogate, it could be a court-appointed guardian. And there's fine print that says what follows is based upon a discussion with that individual. So if they've done that, you have every right to lodge a major complaint.
And I'm in the process, but I think it happens more than people realize, and you can have, it was in a record, and I had no idea
Yes.
until another doctor said, he has a MOLST, and I was like, no, and he was like, well, somebody filled one out.
Yes.
So, yeah.
Every hospital, every skilled nursing facility, every dialysis unit, every hospice, every home health agency must receive if they are enrolling those patients and admitting them to those services, they have to have a MOLST order from the sending hospital. To comply, they really should talk to the family before they do that. But to leave that hospital without a MOLST now is going to create problems. So they create one without taking the proper steps, and that's not right. But that's the background for why that happens.
The other thing, I'm a nurse practitioner, so I've done geriatrics
Yes.
for 40 years. So the other thing people don't realize is the most, if you're going to have surgery, gets canceled and person becomes a full code and many times doesn't get switched back.
Yes.
No one takes the time. And I have seen, I did a geriatric house call program for years. In fact, I've referred to Gilchrist and whatnot. I've seen a lot of MOLST forms that no one knows who filled out.
Yes. So one of the things that I do, I cover over the weekends as part of my coverage obligation is to see new admissions to skilled nursing facilities. And I have learned to take the MOLST that has been sent from the hospital into the room with me and show it to the patient or family and say, is this still reflecting of the condition? I don't accuse my physician colleagues of not doing their work, but I asked, is this consistent with what your wishes are? And I would say about 20% of the time the patients and family says, oh my God, where did that come from? And so I know that this is happening. And when it does, I let the sending hospital know. But yes, that can happen, and that's very frightening to families when that happens, because that's the order. How much time do I have left? 40 minutes. Are you all still with me? You want me to carry on? I'm going to go through the decisions that are in red here.
Just a clarification of what you said. You mentioned something about surgery and the MOLST being
Yes.
canceled.
Yes.
Can you explain that a little bit more?
Yes.
Or maybe you will with the slides.
I probably would not have done that. Many surgeons and many anesthesiologists will not operate on an individual that says they do not want resuscitation efforts, cardiopulmonary resuscitation efforts, if there should be a cardiac arrest in the operating room. And so many hospitals, through their medical board, has a policy that will reverse the do not resuscitate order when the patient goes to surgery. And it should be restored when the patient comes out of surgery. Many times, as you pointed out, it is not restored, so the patient goes into the hospital as a do not resuscitate, has the surgery, gets the order changed, but never changed back. And then that's the one that carries through for the rest of the hospitalization. Now, there are surgeons and anesthesiologists that do not insist on this, so that if you are aware and your loved one is undergoing surgery, you might talk about it. The surgeon is likely to be a little bit squeamish about it. The reason is that no one, the anesthesiologist or the surgery, wants the patient to die in the operating room. And that is a very, very rare event because of all the things that they do for that individual at that moment. And remember, the individual is already hooked up, already has monitors, already is on the breathing tube. And what resuscitation really means in that circumstance is medications, and if that's not successful, then chest compressions to do the full CPR to prevent that patient from dying in the operating room. So it's a very rare event, and in many in many surgeons' eyes, the difference is between DNR in an operating room and full is simply the use of the chest compressions, because everything else has already been done in terms of ventilation, lines, monitoring. Does that answer your question? Yeah. There we go. So let me review some of the decisions. Here's the CPR decision. Unlike what you see on television, it's not the miraculous intervention that returns the patient to their prior state of health. The success rate of CPR varies according to the circumstances. So if you're in the hospital and have a cardiac arrest where your heart stops, remember CPR is only done when your heart stops. 44% of patients initially survive CPR in the hospital, but only 17% survive to discharge. This is the facts that people tend to miss. They hear the 44% and say, those are pretty good odds. They miss the fact that it's 17% survive to discharge. The number that you really want to focus in on when you're talking about this is, what's the 30-day survival and in what condition? If you are in the community, about a third of patients survive CPR, but only 10% survive to discharge. The odds decrease towards survival to discharge because community-based CPR occurs after some minutes. In the hospital, it typically is less than a minute. So interventions can reverse the damage that is done to the brain, to the other tissues when there's no circulation because the heart has stopped. In the community, it takes minutes for the team to get there. And so those minutes translate into survival. There are some communities that are very well trained, have lots of people, have the defibrillators. I think there's one here in this building, probably several in this building, it's such a big building. That has improved the community survival rate some. So there are efforts to improve that survival rate, but still the odds aren't very good. If you're in a nursing facility, 0 to 2% of patients will survive CPR. This is why in a nursing facility, there will be more discussions about it. You might ask, why is that? Well, nursing facilities typically have the sickest of the sick. And so, if you remember the very beginning slide, the benefit of interventions declines with the number of serious illnesses that you have. That if the patient had an event that caused their heart to stop, this wasn't you or me that had a healthy body. Your heart stopped in a very sick, seriously ill body. And so the odds of surviving that event are reflected there at 0 to 2%. And then CPR has its own set of burdens that if you're successful in those first hours and your heart rate is restored, you may have suffered complications from that effort to resuscitate you. For my elders, fractured ribs is a very, very common side effect of the intervention. The fractured ribs may be complete, meaning both sides, and when that happens, patients need to be on ventilators for many days because they can't really breathe efficiently with all their ribs broken. So the burdens have to be considered in this situation as well. Hospitalization is another decision to consider on the most. And you might ask, why wouldn't you want to go to the hospital? Isn't that the place where you get everything done quickly? This is why you need to consider, what is it that you hope the hospital will do for you, and what are the odds that they can do that? For my patients, many go to the hospital because they have symptoms that are unmanageable at home. That's a perfectly rational reason for calling 911. It's 2 in the morning, I'm having shortness of breath that is intolerable, I need relief. So I'm going to call 911 and go to the hospital. That makes a lot of sense. I also want to go to the hospital to understand what's causing that shortness of breath, because maybe it can be treated and reversed medically. And of course, in the hospital, there's a wide range of things that can be done. Once you're in the hospital, all kinds of things become possible that you might not be able to do in the nursing facility or at home. So that's on the one hand. That's why you would go. On the other hand, survival rate may not improve with treatment in the hospital. A cancer patient or an end-stage person suffering with end-stage Alzheimer's who develops shortness of breath, I'm not going to fix the Alzheimer's disease, and I'm not going to fix the cancer by going to the hospital to manage that shortness of breath. Does that make sense? Because that's a severe life-limiting illness, and going to the hospital to manage my shortness of breath, they can do it, but they'll likely also do a lot of other things. They won't just focus on symptom management in the hospital. That's an individual that is best managed in the home or in the facility with having good plans for what to do when breathlessness occurs. Managing that at home or in the nursing facility makes sense rather than coming to the hospital. As I alluded to, the likelihood of aggressive diagnostic testing and intervention is increased when you're in the hospital. And that, for many of my elders, poses risk and harm. I have a 98-year-old man who has heart disease. He's got blood pressure. He had a stroke 8 years ago, and he recovered fully from that. He had some swelling of his ankles about 8 weeks ago. And in the home, I got an X-ray. In the home, I got an EKG. In the home, I began treatment for heart failure that he slipped into because he probably had a small heart attack. So I added an aspirin to his regimen. He was already on a beta blocker. He was already on a statin. So he was getting the best cardiovascular care already. 2 weeks ago, he was visiting his son on the Eastern Shore, and he had ankle swelling. His son took him to the hospital. He was admitted to the hospital. He had studies, just like the ones I had done, a chest X-ray, an EKG, blood work. The blood work showed that he was having another heart attack. They offered him cardiac catheterization. He's 98 years old. He's also a physician, and he said to them, because I've now followed him up, he says, they're nuts. Why would they want to do that? He rejected the cardiac cath because he wasn't sure that the cardiac cath was going to result in any new information or intervention that was going to really help him. And they sent him home on the same medical regimen that he started with. That's an example that when you're in the hospital, the ball starts rolling, And if he hadn't said no, he probably would have gotten a cardiac cath. Now, I know that his kidneys aren't the best. He's 98 years old. And if he had cardiac cath, he might have had worsening of his kidney failures because of the catheter dye that they used to visualize the heart arteries. And I know also that he has pretty old arteries. He had a stroke. His arteries are stiff and have lots of calcification and plaque in them. What happens when you push a needle through those plaques? It breaks off the pieces and causes trouble elsewhere. So those are the potential burdens. And the benefits of the cardiac catheterization could be quite minimal in that it wasn't going to change his treatment very much at all. So he decided on his own in the ED, or no, actually he was in the hospital at that point, that he did not want to have cardiac catheterization. 8 weeks ago when I treated him, we didn't have a cardiac cath discussion. So going to the hospital, expect to have things offered to you because that's what they do. And it's because that's what the protocol is. That's what the algorithm says. But my whole point of talking today is that we want to have individualized medical decision making. Infection and deconditioning can be a consequence of hospitalization. What does deconditioning mean? It means the muscle weakness that comes from lying in bed. And if he lay in bed for 5 days, he's going to be very weak because his muscles are going to atrophy even in 5 days. You probably are aware of the astronauts. When they go up in space, they lose their muscle mass, they lose their bone mass. And you know how fast that occurs? They don't lose it all at once, but it starts the moment of weightlessness. It can be very rapid. Muscle loss can be very rapid. Do you know why that is? Because muscles, for me to keep my big muscles, takes a lot of energy and it takes a lot of nutrition to keep the muscles there. And the body isn't going to invest in maintaining those muscles if they're not being used, particularly when you're sick. It's going to redirect that energy and that nutrition to places that need it. So sick patients, patients who are sick in the hospital, they rapidly decondition. They lose their muscle mass in a matter of days. So one of the things that hospitals are trying to do to combat the deconditioning is early mobilization, getting people up out of bed, even in the intensive care unit, sitting them up as rapidly as they can tolerate it, so that they don't lose muscle mass. As you get older, you start here at age 20, by age 60, by age 90, just through normal aging, the amount of muscle mass that you have is diminished. So you don't have the margins for recovery like you would if you were 20 years old. This is an example of how advanced age reduces your ability to recover and reduces your reserves for recovery. So if my 98-year-old goes to the hospital and is in bed, he doesn't have much muscle to lose before it impacts his function. So that although he went in to the hospital and could walk on his own, because of 5 days of bed rest, he might not be able to walk safely any longer and needs to go get physical therapy. That deconditioning can be avoided if you're not in the hospital. Hospitals tend to keep you in bed, right? They do that for your safety, they claim. And they also say, the nurses might say, I can't get you out of bed until you've been screened by the physical therapist. I see the nodding smiles. To me, that's backwards. They need to be mobilizing and getting you out of bed, and the therapist needs to be there day one of the hospitalization. But deconditioning can prolong the recovery and diminish the chances of recovery as well. The risk of medical errors. How many of you guard the bedside when your loved one is in the hospital? Yeah, there's a reason for that, right? You don't want bad things to happen inadvertently. And then, for patients who suffer from dementia, being in the hospital often upsets the patient. It makes things worse. They often get delirious on top of their dementia. And now they're agitated, they're not sleeping, they're fighting with the staff, they're pulling out their lines. That can be avoided by paying attention to do they really need to be in the hospital? And then, I mentioned this already, in the hospital, the pressure to make decisions is pretty strong. So for patients who are late in the course of a progressive illness or who have very serious illness, a conversation about hospitalization, I think, is important. And particularly nowadays, with modern technologies, the things that can be done in homes, you can do a lot of things in the homes. Like I alluded to in my patient, I can get x-rays, I can get ultrasound studies, I can get labs to come and draw blood in the home, I can get EKGs. I cannot get MRIs yet. In New York City, you can get a mobile MRI, but not yet in Baltimore. But the mobile diagnostics are growing by leaps and bounds, and you can do more and more things in the home. So consider the home option to do your diagnostic evaluation. Skilled nursing facilities have become like mini hospitals. They can do IVs, they can do all these testing as well. So you don't necessarily have to go to the hospital. For patients with late, very progressive or very serious illness, having a plan B for managing symptoms is really one of the most important things, because it's very rational when you're uncomfortable with uncontrolled pain or uncontrolled shortness of breath. It's very rational to call 911 to get help in the hospital. But if you've planned for that and have the help in the home, even in the way of anticipatory medications or a plan, then you may not need to go to the hospital. Comments or questions about hospitalization? There's a couple questions there.
I have heard that one of the reasons that the hospitalizations go to early mobilization is that they found with time that the cantankerous patients that wouldn't stay in bed, that got up and ran around long before the doctors and nurses wanted them to, were the ones that recovered the best. Comments?
I think that's exactly right. The other reason to early mobilization is that it does reduce the risk of hospitalization-related delirium, particularly in patients who have moderate or even mild Alzheimer's. If you're 85 and have any kind of cognitive deficit, your odds of getting delirium in the hospital are over 50%. Delirium can be reduced by early mobilization. Have I said something that upset you? It is so common one of the ways is to avoid being in the hospital. The other is if you have to be in the hospital, certainly get mobilized quickly. Get up and walk around. It's stimulating the brain, helping you connect with the new environment. It makes you feel better. So it has therapeutic benefit as well.
When you mentioned difficulty breathing, I mean, I understand, and I would rather avoid the hospitalization and unnecessary care. It's not indicated at that point. But would difficulty breathing count as pain? That's my one concern, is I don't want to be in pain.
So in the hospice work that I do, I look at those symptoms kind of equivalently. Shortness of breath can be as frightening as severe pain. In fact, it may be even more so, because when you feel short of breath to the point of feeling like you're suffocating or drowning, that's a terrible feeling.
Yeah.
So that we would approach that like we would pain, as something to be managed and treated.
Okay. So I'm wondering if I need to modify my medical directive. I mean, I have stuff in there about pain, but do I need to say breathing difficulties?
Yes, that would be a useful modification. For patients that have heart disease or lung disease, that would be an important modification, because you're more likely to experience that severe symptom than pain. Whoops. I'm getting ahead of myself here. The tube feeding question. When decisions about tube feeding comes up, this is a very emotional topic, because how could you deny food and nutrition to a patient by not using the tube feeding? So that's on the one hand. And on the other hand, you say, what about my mom who's going to feel hunger and wants food? How could I not feed her? So these are the arguments for doing tube feedings. And it's the arguments that you hear, and it's a very important concept to understand that tube feedings is a medical intervention. And like every medical intervention, there are benefits and there are risks and burdens to it. Tube feeding is not the same as careful spoon feeding or hand feeding. And for patients who have esophageal food pipe problems, tube feedings is life-saving and life-prolonging in ways that ensure great comfort and great longevity, and tube feedings is appropriate for that group of individuals with head and neck problems. Tube feedings is not appropriate for patients with advanced dementia. Does that come as a shock to you all? Used to be that a large number of patients with advanced dementia got tube feeds. They got a feeding tube placed. They used to think, they as us, the medical profession, used to think that it helped them survive, helped them avoid aspiration pneumonia. But studies have shown that it doesn't provide the benefits that it thought they would, the tubes would. And you can look this up. The American Geriatric Society is part of the Choosing Wisely program. Has anyone heard of the Choosing Wisely program? It's a program that was started probably 5 years ago by the various medical societies that agreed to identify the 5 top things that their profession is doing that should no longer be done. That's the Choosing Wisely. Look at that, because this is the honest professional societies saying these things that we used to do should no longer be done. The American Geriatric Society says tube feeding in dementia patients should not be done. There are a few other societies. The American Gastrointestinal Society has also agreed with that. The reason is that the tube feeding doesn't get you the benefits, doesn't get you the benefits that you thought it would in dementia patients. In fact, tube feedings may actually increase the risk of aspiration pneumonia. When I was much younger and tube feedings were just being started, that was the major reason why they were being done, was to prevent aspiration. Think about it. When the patient isn't able to swallow safely, food goes down into their windpipe and causes coughing and sometimes significant respiratory distress from that aspiration of the feeding contents. And so it seemed perfectly obvious that if you put a tube to bypass this, that it would prevent it, but it doesn't. The reasons why it doesn't is that tube feedings causes the stomach to fill up, right? That's kind of a normal thing. And the stomach may push the food in the right direction, the liquid food in the right direction, or it may push it back up into the esophagus and into the lungs. You and I, when we have that, it's called reflux. Sometimes the reflux can be enough to cause aspiration in a patient who doesn't have the ability to manage their secretions or to manage whatever gets in their mouth. The other reason why aspiration continues is that when people get tube feedings, the normal saliva production continues. So now I have a patient that can't swallow safely, receiving tube feedings that cause more saliva and more secretions in their mouth. They have two options. One is to drool and to let it come out that way, and the other is for it to not go down the right tube and into the lungs. So now that we know more about it, we don't recommend tube feedings for advanced neurologic conditions. That's a tough one for people. The alternative to tube feedings is very careful hand feeding. And patients with advanced dementia and swallowing problems, properly positioned, meaning leaning forward, chin down, small bites, small sips, even given by a syringe, can sustain that person. And so hand feedings is the alternative to tube feedings in patients with advanced dementia. It also feels more compassionate, more humane, more human to offer the spoon feedings as opposed to a more mechanical tube feeding. Comments or questions about that one? Behavior-modifying medications have become an important topic of discussion in advanced dementia. That's because patients with even early or moderate dementia often have behavioral complications. Irritability is very, very common. And then about a third of patients with dementia experience hallucinations, some of which are very disturbing and can lead to combativeness or rejection of care. And both the patient and family are very distressed by these symptoms. However, medications have substantial risks and adverse events associated with them. The drugs that are used to manage the behavioral aspects of advanced or patients with dementia often carry a black box warning. Are you familiar with that concept? The FDA, the Federal Drug Agency Administration, for drugs that have to be used very cautiously, they have a box that's outlined in black, bold lines. And it's a black box warning that says these drugs actually increase mortality in patients receiving them and should be for very focused, short-term use. I'm looking at your expression. You don't believe this, but it's true. And yet these drugs are used very, very commonly because these symptoms of hallucinations, agitation, irritability are hard to manage. And the family and the doctor or the nurse practitioner are often asked, can't you do something about mom's behavior or dad's behavior? They have other side effects too, as you know. They dull the personality of what's left of that patient's personality. And that makes it even harder for them to interact with their environment. And if they're initiated in the hospital during that episode of delirium, the skilled nursing facilities may reject placement because of that medication. Because the skilled nursing facilities know that if they get patients like that, they may be a behavioral problem. And two, if they use these medicines, they may be subject to punitive survey. I'm sorry, this is the inside baseball on this. But surveyors every year visit skilled nursing facilities. And on their checklist of things to check is the use of these medications. It's not that they forbid the use of these medications. It's just that these medicines should be used for very focused symptoms for very short periods of time. And if a patient inadvertently or intentionally remains on these medicines for a long period of time, that will result in a citation against that facility. And the facility doesn't want that citation, so they try to avoid it. So, yes, Haldol, Zyprexa are the very common ones that are used. Haldol. It's an antipsychotic. Yes, Abilify is another one. There's a whole group of these drugs that are used for psychotic symptoms, but in this population of patients can be very harmful. And the studies that have been done actually show a higher mortality risk if individuals are on these drugs. Studies also show that these drugs are no better at 8 weeks than placebo, which is why the FDA says that they must be short-term use.
So if a person's having hallucinations or nightmares or terrors or whatever, there's really not a whole lot that can be done for them.
Boy, you've hit the nail on the head. The disturbing symptoms, the night terrors, the nightmares, and the hallucinations can be very, very disturbing. And what do you do about them? So geriatricians use these drugs. We use them sparingly, and we say, I'm using this drug to treat this hallucination. And I'm going to monitor the effectiveness of that drug in managing that symptom, that hallucination. If it does, that's a good thing. If it doesn't, I'm going to stop that medicine. That's a very judicious, careful use of the medicine, targeted symptoms. If it works, after about 4 weeks, I'm going to try to taper that medicine and stop it. Gradual dose reduction. If gradual dose reduction causes the symptom, the hallucination, to come back, then I'm going to increase the dose again. If I've done those things, I've now prescribed and used the drugs in the way that's clinically acceptable and compliant with the FDA regulations and compliant with a surveyor if your loved one happens to be in a facility. If I don't check, and I'm just giving you the medicines for general agitation, that's probably not going to be sufficiently targeted to meet those criteria for appropriateness. Agitation should be considered a symptom that warrants investigation, looking for why the patient is agitated. And it could be something as simple as, at 9 o'clock at night they're hungry, or at 9 o'clock that night they're wet, or they've had a bowel movement, or they've had some other type of medical situation that they need addressed. Agitation also remember, patients who have advanced dementia, they can't talk about what's bothering them. So you as the caregiver have to be the best detective to figure out what the trigger is for that agitation. We should not use these kind of medicines for agitation. If there's a specific hallucination, it's okay. But for generalized agitation, these are not the drugs to be using. Be the best detective that you can to figure out the triggers. And it may be environmental. One of the trends in nursing facilities, and certainly we're beginning to use this in hospice, is to use environmental factors. For example, music. Music can be very calming to patients with advanced dementia. Got to get the right music. Don't want to be playing rock for some of my 90-year-olds. So do the medical history and find out. Aroma is another one. There's a lot about aromatherapy. There are these robotic cats. You can buy them at Walmart for under $50. These are lifelike animals, cats, that purr, they move about. For certain people, those cats can be very calming. Place them on the laps of an agitated patient and see if it calms them down. Have them pet it. We're using those now as non-pharmacologic ways of dealing with agitation. So be the detective to figure out what the triggers are before you reach for these medicines or ask your doctor for these medicines. Answer your question? Yeah. Our staff likes them so much that one of our teams got one for themselves. Helps relieve the stress of the day. Are you all still with me? I've got a couple more to go. I can stop anytime. So this is a hard one. I want to comment about hospice. Of course, I'm from Gilchrist, so we have hospice. Hospice is the standard of care for life-limiting illness for patients with a prognosis of 6 months or less. That's because it offers a comprehensive range of services to both the patient and the family that can be very, very beneficial to help during that very challenging period of time. There are lots of misconceptions about hospice, and open to any of your questions about that. But it's worthwhile to get information about hospice well in advance of any need for it, because it's such a difficult decision to consider. And I'm open to other questions after we talk or after I finish on an individual basis if you'd like. I do hear very frequently from families who I meet who've enrolled their family member in hospice that one of their main regrets is that they didn't do it sooner, because it can be so helpful. So if we've done a good job on crafting and navigating our medical journey, you'll have medical care that's consistent with your goals and values. You'll have a unified family. I see lots of fractured families as a result of this end of life and the care for serious illness. It's so stressful that to be out ahead of this so that you keep your family together, and that's one of the benefits of doing this. And then if you have your own legacy, that you're writing your own life story, this will be a successful chapter in it. If you're the medical warrior and you want your medical history to be prominent, you want that to be part of your life story too, and that is okay. So that's all I have in the way of prepared remarks. I'm open for questions. Otherwise, we can stop.
Could you talk a little bit about your practice and how available you are or aren't to, say, if we all wanted to sign up with you?
I am.
How likely would that be?
You might have noticed in the brief bio that I have a small practice. I have not taken new patients in probably about 4 years. I'm getting a little gray around the edges, and I'm going to be retiring soon. Soon meaning, I don't know yet, like years, but I'm not taking new patients and haven't.
But you supervise.
Yes, I do. Yes.
So that's what I mean. Like, you or your practice.
Yes. So we have, we meaning Gilchrist has, we have programs that are designed for in the home. So that's our Gilchrist Elder Medical Care at Home. I think I have actually a slide. Let me prematurely. I'm sorry, did you take it down already? The last side has a contact number. It's 1-888-823-8880. And that will get you to a care navigator. A care navigator is a knowledgeable layperson about all the kinds of programs that Gilchrist has, but also additional community resources. And so they can walk through the at-home program. We also have our a geriatric consultation service. That is up at Broadmead, which is a retirement community in Cockeysville. That consultation service takes consultations from across the region. Yes, it will be on the website as well. And then we have our practice is primarily devoted to the care of seriously ill and those with advanced age. And so we work in multiple facilities. In Howard County, we work in the 3 Lorien facilities. And in Baltimore County, we work in nursing facilities as well as a whole bunch of other assisted living communities as well. And then, of course, we have the home program.
How do you manage or coordinate with Medicare with these determinations for hospice, need of hospice?
Yes. So as part of the admissions process, we identify that Medicare would be the payer for that. We just validate that Medicare is functioning and that the policy, and then that's it. There's no other coordination. If the patient is enrolled in hospice, you may know that Medicare hospice benefit is an all-inclusive benefit that covers basically all the human services that come into the home and then any medications that are related to the terminal condition. And so that's, and you will see explanations of benefits, but no bills, unless you're getting some medications, say glaucoma medications, through the Part D plan that you might have.
So have you had situations where Medicare says, it's not a hospice situation?
You're talking about hospice eligibility and meeting the Medicare guidelines for eligibility. Yes, the admissions process is exactly that. So we have nurses who are operating in a number of, here in Howard County, we have nurse liaisons that are at Howard County General Hospital, that are at the various facilities as well, that are doing those evaluations upon request. I and some other of the hospice physicians are in the background that are reviewing the medical content and making those determinations. If a patient is not eligible for technical eligibility reasons, meaning their prognosis might be 2 years instead of 6 months, we do have a program called Elder Medical Care, and that will get at no charge to the patient a social work, one face-to-face visit, and then follow up on a regular monthly basis.
And that's at home if the patient
That's at home, yes. Yes, we don't have that. It's not available in facilities because facilities theoretically have social work services.
Thank you.
Is the presentation you used today available to, to download or anything like that?
It's going to be.
When the parish updates their very outdated website, we're hoping to have the ability to have them linked there as well. But right now we can't do that. They don't have the space to do it. So we have the DVDs in the Interfaith Library.
Have I said anything that has upset anyone? I'd like to clarify that before you leave, so I don't want people leaving upset by anything I might have said.
Very enlightening. I mean, some of it was, let's say, awareness raising, a lot of the things I thought I had, because I've been through the process of preparing all these forms, so I thought and I've had conversations with my family.
Yes.
That I'd pretty well covered everything, but your discussion helped to alert me to a lot.
There are a number of books on medical decision-making that are written for the public that are out there that are really very good, that go into this much more detail. So you could easily Google that to get a list of.
I read that one that everybody was reading recently. I can't remember the name of it now. It's very popular. It's on. Yes.
Oh, Being
But
Mortal.
He didn't go into this.
He did not. Schneider is one, and I'm sorry, I'm blocking on the names as well.
Yeah.
But there are some geriatricians that have written books that basically go through the same kind of how do you weigh risks and benefits, and they do it by disease. So for example, prostate cancer, how would you go about weighing that? Cardiovascular health, like the catheterization, it's coming out of resources like that. Because it's really complicated, and you know, the doctors, we struggle with making good medical decisions ourselves. And then how do we expect that from our families? You know, particularly if we haven't explained it particularly well.
Do you have a copy of the slides available? Some of
copy.
that information is very, I think, very valuable.
I can make it available.
Oh, good, good, right. But
I-
there's just 2 copies of the tape, right? So, no, I'm just thinking, take him home and show my brother and sister, and talk about some of the distinctions that you had up there.
I'm okay with that. Yeah, I'm okay with that if you want to do that. I know, it's a long time to sit. You're welcome.
I want to thank you so much. I hope everyone agrees with me that this was absolutely very good. It was. It was. This was beyond my expectations, and I'm just extremely pleased. And I'm sure that we're going to have a lot of people check those DVDs out. So thank you so much.